Hi guys, welcome back to the Read Harrison series. Dr. Patil here, and in this video module we will be learning about two important and major complications of diabetes, that is diabetic nephropathy and diabetic neuropathy. The underlying mechanisms why these complications happen we have all discussed in the previous video modules. So if you are someone who is connecting to me now for the first time, I would recommend that please go through all the other videos that we have done on the diabetes. So today let's learn about nephropathy and neuropathy. But before we go into the topic, let's revise one MCQ based on what we have discussed in the previous class. The previous class was based on DKA and HHS. So let's see if we can answer this right. False statement about acute diabetic complications. We know that DKA, HHS and hypoglycemia are three acute complications of diabetes. Let us see which of them is a false statement related to these. First statement says euglycemic DKA is characterized by blood glucose less than 250 milligrams per deciliter. Now, diabetic ketoacidosis typically happens when blood glucose level is more than 250, but under certain circumstances like patient being on SGLT2 inhibitors, they can develop DKA even when their blood glucose level is less than 250, and in such cases we call it as euglycemic DKA. So this statement is true. Euglycemic DKA refers to development of DKA with blood glucose level less than 250 milligrams per deciliter. Okay. Next statement. Patient of HHS has more fluid deficit than patient with DKA. This point I have elaborated again and again in the previous class. Whenever we have a patient with HHS, they tend to have more fluid deficit because DKA patients present early. Why do they present early? Because the presence of ketosis makes them feel the symptoms early, so they come early. So when they present, they have relatively less fluid deficit, around 6 liter. But patients with HHS may have fluid deficits upwards of 6 liters, usually 8-9 liters of fluid they would have already lost when they come. So this statement is also true. Now the third, bicarb replacement in DKA is not indicated if pH is more than 7. So in the previous class, we have specifically learned that the bicarb replacement in a patient with DKA is indicated when pH is less than 6.9. So if it is 7 or more, of course, I don't need to do the bicarb replacement. So this is also true. The last one, DKA carries higher mortality risk than HHS. True or false? We have learned that HHS has more fluid deficit than DKA because they present late. So the chances that they succumb to hypotension or shock is also high in HHS, not in DKA. Of course, DKA has higher mortality, but not higher than HHS. So this statement is false. So in terms of mortality, when we talk about mortality, the hyperglycemic hyperosmolar state carries higher mortality than diabetic ketoacidosis. So the answer for this question will be option D. It's a false statement. All other statements are true. Okay. Pretty good. So let's start with the diabetic nephropathy. Why this is an important topic? Now, first reason why I consider this as a very important topic is that diabetic nephropathy is the most common cause for CKD worldwide. So if there is someone with a chronic renal failure, majority of them, it accounts for more than 2/3 of all cases. 2/3 of all cases. So whatever you study in pathology, right, chronic glomerulonephritis, because of so many causes, they all account for less than 1/3 of cases where patients are called as having CKD or end stage kidney disease. That also means that the diabetic nephropathy is the most common cause for chronic hemodialysis. Means if someone is requiring dialysis, it is most likely because of diabetic nephropathy. That makes it a very, very important cause. Now the question is, everyone who has diabetes will end up developing the diabetic nephropathy? The answer is no. So it affects 20 to 40% of diabetics develop. 20 to 40% of diabetics develop diabetic nephropathy. That means not everyone, many of them will live their life without developing the diabetic nephropathy despite having diabetes. Okay, so these three statements are very, very important for us to understand the disease. CKD and dialysis के लिए most important reason क्या है worldwide? It is the nephropathy. So it even accounts for 2/3 of the patients who are requiring dialysis today are because of diabetic nephropathy. So if you walk into a like dialysis room, you see 10 patients, 5 to 6 or more than that are because they are in that room because of the diabetic nephropathy. Okay, but there is one point to think: not everyone with diabetes will develop nephropathy. So then what are the factors that decide who is going to develop the nephropathy? Because if everyone is going to develop, then it should be 100%, right? So what are the factors that influence someone to develop diabetic nephropathy? Of course, the number one and the single most important, the first and the most important risk factor is the glycemic control. So better is the blood glucose control, lesser chances that you will develop the diabetic nephropathy. So someone with HbA1c 7 or less has much less chance of developing diabetic nephropathy than someone with HbA1c 10. Someone with HbA1c 10 has less chance of developing diabetic nephropathy than someone with HbA1c 12. So glycemic control is an important risk factor. The HbA1c level more than 7 significantly starts increasing the risk of developing diabetic nephropathy. That's the first factor. Second factor, presence of comorbidities. Presence of comorbidity. So if I have some additional diseases that increase the risk of developing diabetic nephropathy. So that includes, the most important one is hypertension. Hypertension and diabetes are deadly combinations. Hypertension. Second, smoking. So that's why doctors beg the patients to stop smoking once they're diagnosed with diabetes or hypertension. It's a deadly triad: diabetes, hypertension, and smoking. Deadly triad. Okay. What other comorbidities can influence the risk of developing diabetic nephropathy? Hypertension, smoking, and dyslipidemia. Means if you have high LDL-C, low HDL-C, they also increase the risk of developing diabetic nephropathy. Third, the genetics. So if you have a family history of another person with diabetic nephropathy, when you become diabetic, your chance of developing diabetic nephropathy significantly increases. So family history is the third most important risk factor. Okay. Fourth, exposure to nephrotoxins. Exposure to nephrotoxins. Now, why this is important? Because many diabetic patients often end up developing diabetic neuropathy where they have heightened perception of pain. So to control pain, they may end up taking painkillers, right? Now, they may also develop other complications to treat, like diabetic foot infections. We may give nephrotoxic antibiotics, right? And they also need repeated investigations. So we may give nephrotoxic contrast agents for doing CT or MRI or other radiological imaging. So nephrotoxins like exposure to NSAIDs, aminoglycoside antibiotics, because see, again, one more complication of diabetes is that they repeatedly go through UTIs, and to treat UTIs many times we end up using antibiotics. Sometimes it is aminoglycosides as well, and we know that they are all nephrotoxic, right? So aminoglycosides, then contrast agents, these are all. Now tell me, among these, what risk factors are controllable? You can say that almost everything except the genetics can be altered. For example, glycemic control. अगर मैं diabetes अच्छे से control कर लूँगा with the use of medications, insulin, whatever it requires, so I can minimize the chance of this patient developing nephropathy. और अगर already develop हो चुका है, तो I can slow down the progression of the disease. दूसरा क्या है, इन comorbidities में hypertension हम manage कर सकते हैं. We can manage hypertension. Of course, smoking is a choice, it's not a disease. Dyslipidemia भी हम manage कर सकते हैं. Only genetics, family history is something that we cannot manage. Exposure to nephrotoxins, as a doctor, it becomes a duty that whenever you are dealing with a diabetic, if you are exposing them to NSAIDs, aminoglycosides, or any nephrotoxic agents, including contrast agents, we have to take the necessary precautions about hydration and other parameters. Okay, so these are the risk factors. Now let us say that despite our attempts, patient develops the diabetic nephropathy. Now what is going to be his natural course of illness? This is where the most important understanding of diabetic nephropathy lies. So when we diagnose the diabetes, let us say I have diagnosed the diabetes at particular age, at 35, 36, 40, हमने diabetes diagnose कर लिया है, right? Now once I diagnose the diabetes, if it is type 1 diabetes तो शायद उसी टाइम पे स्टार्ट हुआ होगा. Of course the patient would have presented before 20 mostly, but if it is type 2, diagnosis से पहले he would have spent 5 years, 10 years with diabetes without any symptoms, without diagnosis, because remember majority of the type 2 are detected on screening. तो कुछ भी हो, टाइप 1 टाइप 2 हमने डायग्नोस कर लिया, उसके बाद ये डायबिटिक नेफ्रोपैथी कैसे प्रोग्रेस करेगा. सो प्लीज रिमेंबर फर्स्ट 5 years we will divide this as pre nephropathy stage and silent nephropathy stage. इस स्टेज में क्या होता है, we have already learned that glucose, blood glucose level is increased and it's an osmotically active substance. So जब blood glucose level ज़्यादा होगा, तो now when I have to filter it at the kidney, what has to happen to the GFR? More is the solute, GFR starts increasing. So as I have to filter out more glucose, I have to increase GFR. So in the initial stages, there is increase in the GFR. This is just a counter mechanism or compensatory mechanism to cope up with this increasing glucose load. And that is where the problem with the kidney starts. So initial stage mein kya hoga? Like I have put a graph here. On the bottom, on the x-axis, I have plotted the years of the diabetes, and on the y-axis, I have plotted the estimated GFR. Now, normal GFR is somewhere around, let us say, 90 to 120. In the initial stages, because of the hyperglycemia, GFR kya hone lagega? The GFR starts increasing. In the initial stages, the GFR starts increasing. So it goes up. It starts increasing. So first stage, GFR starts increasing. The reason for this increased GFR is hyperfiltration. Hyperfiltration. So hyperfiltration starts increasing the GFR. Now this nephrology has a concept called as hyperfiltration injury. Okay, how many of you go to gym? Raman, okay, let me address your query, Raman. I will take it up. Okay. How many of you go to gym and are on protein supplements? आपने सुना होगा, right? You might have heard that if you're going to gym and you're taking these whey protein supplements, many doctors say that don't take protein supplements because it will cause renal injury, kidneys खराब हो जाएंगे. How true is that? Is there any study to say that if you take protein supplement, there is a chance of renal failure? To counter that or to support that, many doctors say कि सर बहुत से जो किडनी पेशेंट्स होते हैं, डॉक्टर्स बोलते हैं कि प्रोटीन कम खाओ. दैट आस्क देम टू टेक reduced amount of protein. Okay, please remember, as there is more amino acids or glucose, right, filtered during the glomerular filtration, the kidneys have to do more work. So there is hyperfiltration, and hyperfiltration is known to cause the injury to the glomeruli. So this hyperfiltration starts causing the glomerular injury. So if you're taking exorbitantly high amount of protein, that can cause hyperfiltration injury. Now this is debatable कि कितना protein को हम high कह सकते हैं. Is it like 1 gram per kg? Of course it is safe. 1.5 gram per kg, 2 gram per kg, 3 gram. That is bit debatable when hyperfiltration injury starts, but there is a possibility. So जैसे high amount of protein intake can cause, similarly high amount of blood glucose can cause this hyperfiltration injury. So during this period, जब kidneys are doing hyperfiltration, what do you think should happen to the size of the kidney? If muscles work more, they develop hypertrophy. Similarly, when kidneys work more, they also develop hypertrophy. So at this stage, there is renal hypertrophy. As there is hyperfiltration injury happening, we start developing renal hypertrophy. So kidney size increases. That's why whenever you see a patient with diabetes and you ask them to get an ultrasound done, then you pay attention to the size of the kidney. The size of the kidney may expand in the initial stages. But once the hyperfiltration starts causing the glomerular injury, then what will happen to the GFR? GFR had rise in the initial stages of diabetes, GFR is high. But once the glomerular injury starts happening, the GFR starts decreasing. So now it drops down. and when it has dropped down, the GFR might have come down to the normal range, that is like 90 to 120 normal range mein aa jayega. This stage we call it as incipient stage. Now at this stage, I will not see any major abnormalities in patients' day-to-day activities. Of course, the silent stage or pre-stage, no abnormalities. Only thing is that background mein kidneys are working more and more to filter more glucose and reabsorb more glucose, and that is causing the injury to the glomeruli. Sorry. As the injury progresses, the GFR starts decreasing. Now, how do I diagnose at this stage, incipient stage? Now, this renal hypertrophy that I was seeing in the silent stage, it will show up in the incipient stage as loss of corticomedullary differentiation. Corticomedullary differentiation. Now, अब इसका मतलब क्या है? Normally, when I get a ultrasound of the kidney done, you might have seen that it looks like that, where you have the medulla and the cortex. There is a clear differentiation. Now it all becomes blurred, where the medulla ends, where the cortex begins. We will not be able to appreciate. In simple words, हम इसको कह सकते हैं कि हाँ, structural changes become evident in the incipient stage. Okay, अभी GFR normally है, it was rising, it has come back to normal. So in terms of kidney functions, I may not see major changes, but I can start seeing one change. Because the glomeruli are getting injured. So hyperfiltration था, यहाँ पे glomerular injury start हो जाता है. Glomerular injury start हो जाता है, though GFR is in the normal range, and that results in one major change. What is that? Now I start filtering out albumin because glomeruli are injured. I start filtering out albumin and I start losing it in the urine. How much albumin I may be losing here? Very minimal. So that minimal albuminuria, we will call it as microalbuminuria. Microalbuminuria. I start developing microalbuminuria at this stage, in the incipient stage. Now, at this stage, if I do the kidney biopsy, of course, I will see the changes in the glomeruli. What changes I will see? Mesangial expansion and glomerular basement membrane thickening. Now, as time progresses, the GFR further starts decreasing. It further starts decreasing. So when it further starts decreasing, that stage we will call it as overt nephropathy. So as a doctor, मुझे कैसे पता चलेगा कि overt nephropathy है? I will get to know it is overt nephropathy when this albuminuria, the amount of albumin I start losing, increases and I get into macroalbuminuria. Macroalbuminuria. Chandan, very good. So when I say micro, it is 30 to 300 milligrams per day. When the albumin lost per day is more than 300 milligrams, then we call it as macroalbuminuria. So at this stage, I start developing macroalbuminuria. So I start losing larger quantity of albumin in the urine. GFR continues to decline. At this stage, if I get the biopsy, in the biopsy, we start noticing that the interstitium, the connective tissue, and the renal tubules, they are all getting fibrosed, and mesangial nodules, which you call as Kimmel-Steele-Wilson nodules, they start becoming evident. It's called as Kimmel-Steele-Wilson nodules, which is a very important MCQ from pathology. जैसे टाइम और बढ़ते जाएगा, फाइब्रोसिस और बढ़ेगा, mesangial nodules और बढ़ेंगे, GFR will decrease further, and when the GFR is less than 30, we will call it as end stage renal disease or end stage kidney disease. At this stage, patient will have all the complications of renal dysfunction, in the sense hyperkalemia, acidosis, fluid retention, edema, and either we have to manage at this stage with dialysis or renal transplantation. So we can divide this progression into blocks. So initial 5 years, at the outlook, major changes may not be apparent, but background में injury चल रहा है, hyperfiltration चल रहा है, and the kidneys are trying to compensate by developing the hypertrophy. If I address the glycemic load at this time and control the blood glucose level, it is reversible. So in this initial pre and silent stage, it is reversible. Even to some extent, the early years of incipient stage, the diabetic nephropathy is reversible. But after later part of incipient stage, or once macroalbuminuria is evident in urine, when you're losing more than 300 milligrams per day of albumin in urine, it is not reversible. It will either stay like that or progress further towards the end stage kidney disease. Okay, so this is the summary of how the diabetic nephropathy progresses. Now think about it, like you are a doctor and you get a patient with diabetes. Of course, I am worried about my diabetic patient developing all these progressive changes, right? So first thing is that when should I start screening for it? अब मुझे डिटेक्ट करना है, स्क्रीन करना है, तो what should be the test that I should do for screening the diabetic nephropathy? And if I recognize कि हाँ diabetic nephropathy है, of course based on this pattern or estimated GFR, I can get to know which stage it is. Stage भी पता लगाने के बाद, I don't want him to progress further, so how can I prevent the progression? Okay, so now when and how to screen for diabetes. So first, diabetic nephropathy. So first we will address when. So if it is a patient with type 1 diabetes mellitus, अगर ये type 1 DM का patient है, then we know that as soon as the type 1 DM patient enters into a stage of absolute insulin deficiency, they present with symptoms. So they wouldn't have spent years together before the diagnosis. They would have spent days to months before the onset of diabetes. So that is why the screening should start 5 years after the diagnosis. 5 years after the diagnosis. But what if I'm dealing with the type 2 diabetes mellitus patient? If I'm dealing with type 2 diabetes mellitus patient, we know that type 2 are generally asymptomatic. So by the time they present with type 2 diabetes mellitus कि हाँ कोई 35 साल 40 साल का आदमी आया था, I screened and I got the diabetes diagnosed. I don't know इससे पहले कितने साल वो diabetic था, 5 साल था, 10 साल था, 15 साल था. We never know because they remain asymptomatic for a very long period, and during that period these changes would have already progressed. So at the time of diagnosis he may be anywhere. He may be in overt hypernephropathy stage, incipient stage, silent stage, pre-stage, क्योंकि मुझे पता नहीं कितने साल हो गए diabetes start होके, right? So that's why for type 2 diabetes mellitus, the recommendation is at the time of diagnosis. This दिन आपने diagnose किया, also screen for the presence of nephropathy. हो सकता है he may already have the nephropathy. Now the question is how? What investigation I can sorry, what investigation I can do to diagnose? Chandan Batra, very good, very good. हाँ, so the preferred investigation of choice. देखो एक टेस्ट हो सकता है अल्ट्रासाउंड which can detect this loss of corticomedullary differentiation. One more investigation हो सकता है renal biopsy where you can see these changes of glomerular basement membrane thickening, mesangial expansion, KW nodules, all that. But of course biopsy is not going to be the investigation of choice because it is invasive, risky, hematoma हो सकता है, complications are possible. So of course I'm not going for that. Ultrasound will not detect the early stages, right? Only when there is clear loss of corticomedullary differentiation, the radiologist will be able to commit and say that, हाँ sir, ये हो सकता है diabetic nephropathy. But this microalbuminuria, that is the earliest recognizable change in a patient with nephropathy. Earliest recognizable change. So that is why Firoz and Chandan, very good. So that's why that will be the investigation of choice. Now there are two ways to record the albumin loss in the urine. One is 24-hour urine albumin estimation, but it is cumbersome, right? So when I ask how, so you have two choices. One is 24-hour urine albumin estimation. How much albumin you are losing in 24 hours of urine. But it is of course cumbersome because patient needs to collect urine for 24 hours, then bring it to the hospital or the lab and hand it over to the lab. Quite messy. What alternative we have? I think Chandan had already mentioned. The alternative, which is not as great as 24-hour urine albumin, but it is almost comparable in terms of the efficacy, sensitivity and specificity, that is UACR. UACR on spot urine sample. Spot urine sample. Now what do I mean by that? UACR stands for urine albumin creat ratio. Means in the urine we will calculate how much is the albumin, how much is the creatinine. Because you know creatinine we excrete in urine, and in the diabetic nephropathy we may be excreting albumin also in the urine. Now we will take one sample. We are not collecting 24 hours of urine. We take one sample, calculate how much is the albumin and how much is the creatinine, and take that ratio. Now if I am following the 24-hour urine albumin, then if the 24-hour urine albumin is less than 30 milligrams per day means 24 hours, right? Then we will count it as normal. We would say that there is no major albumin loss. But if it is 30 to 300 milligrams per day, we will call it as microalbuminuria. We will call it as microalbuminuria. So in the previous slide, when I said microalbuminuria, we are referring to 30 to 300 milligrams of albumin lost in urine per day. And when it is more than 300 milligrams per day or per 24 hours, we will call it as macroalbuminuria. Macroalbuminuria. As I've already told you, once there is macroalbuminuria, diabetic nephropathy is not reversible. आप progression को slow कर सकते हो, reverse नहीं कर सकते हो. Now what should be the criteria if I am following urine albumin creat ratio? So on the spot sample, we are basically calculating how much is the albumin in per liter of urine and how much is the creat. That is basically urine albumin creat ratio, not the blood, urine sample. You have to remember the same numbers. There is no difference in the UACR for the numbers. Only change we will do is, instead of per day, we will say per gram. So for every 30 milligram, like for every 1 gram of creatinine lost in urine, if I am losing less than 30 milligram of albumin, then it is normal. So if it is less than 30 milligram of albumin for every gram of creatinine, it is normal. If it is 30 to 300 milligram of albumin lost in urine for every gram of creat lost, then it is microalbuminuria. And if I am losing more than 300 milligrams per gram of albumin per gram of creatinine, then it is macroalbuminuria. So now what do we understand? Once I have diagnosed diabetes, if it is type 1, immediately मुझे diabetic nephropathy screen करने की जरूरत नहीं है. 5 साल बाद हम screening start करेंगे, and annually we will keep screening. हर साल we will keep screening. How am I screening? I am primarily taking the help of the 24-hour urine albumin or urine albumin creat test on the single sample of urine. Once it is more than 30, I know that diabetic nephropathy has started. And from there, whether it is micro or macroalbuminuria, I will have a rough idea whether I am dealing with an incipient stage or an overt nephropathy stage. Okay, so that is one, or alternatively, I can follow UACR. And one more approach that we can follow other than this is estimated GFR. Estimated GFR or eGFR. Now this eGFR will also give me an idea where the patient stands. If the GFR is more than normal, he is in pre or silent stage where hyperfiltration is going on. If it is in the normal range with microalbuminuria present, he is in the incipient stage. And if GFR has started declining, then we know it is overt nephropathy. And when it is very low, we know that it is end stage renal disease. End stage renal disease. Okay, so this now we know when to screen. चलो अब screen भी कर लिया है, and I noticed that the patient is having diabetic nephropathy. Surendra, I will do it. I'll do it. So when I'll get to know that, like, how do I now slow down the progression? Because diagnosis तो हो गया है that okay, this patient is having diabetic nephropathy. How do I slow down the progression? Okay. So please remember diabetic nephropathy with microalbuminuria may be reversed. If you open the Harrison, there's a beautiful image of biopsy changes of the same patient who had diabetic nephropathy. So initial stages का एक biopsy picture है, and in that biopsy picture you can see the glomerular basement thickening and mesangial expansion. So somewhere in the incipient stage, patient was there and he had microalbuminuria. Once they managed his diabetes and other parameters, a repeat biopsy was done years later, which shows that these changes have reversed. So that's why if you catch hold of the nephropathy in the early stages, it is good. So इसलिए please remember when to start screening. If it is type 2, at the time of diagnosis itself. And if the patient is in the early stages, that is still in the microalbuminuria stage, it may be reversed, and we are doing a good job for the patient. But nephropathy with macroalbuminuria already losing more than 300 milligrams of albumin, it is not reversible. It is not reversible. It is not reversible. Now he will continue to progress, and when he is going to continue to progress, the question is, how do I slow down the progression? So what studies have shown? Interventions known to slow down or halt progression. What all can slow down or halt progression? So first thing that can slow down or halt the progression is glycemic control. Glycemic control. And we already know what is the HbA1c aim. So try to get HbA1c less than 7%. That will slow down or halt the progression of the diabetic nephropathy. He will not go on losing the GFR that we saw in the previous graph. दूसरा क्या कर सकते हैं? If they have a comorbidities, we just learned that the presence of hypertension worsens the situation. So control hypertension. Control hypertension. So if I have to control hypertension, what is the target BP? This is an MCQ that has been asked. Target BP. How much should be my BP? Let me give you an example. Right? Let us say I started a patient with a diabetic nephropathy, 180, 110 tha. I started him on treatment, and during follow-up it is 150, 90. Is it good for the patient's progression of the disease? No. This BP will still cause the glomerular injury. So we need to achieve this target. What is the target? I think Chandan wrote it perfectly all right. That is, the target BP should be less than 130 by 80 millimeters of mercury. 130 by 80 millimeters of mercury. That should be our target BP. So get the HbA1c less than 7%, get the BP less than 130 by 80 millimeters of mercury. If you're able to do this in a patient who is still in a microalbuminuria stage, you may able to reverse his nephropathy. If he's in macroalbuminuria stage, at least you can slow down or halt the progression. Okay. Now there is a third and a very important drug that can slow down the progression of the disease or decline in the GFR. That is ACE inhibitors or ARBs. So even in a non-hypertensive diabetic, if they have nephropathy, using small dose of ACE inhibitors or ARBs slow down the decline in GFR. Like this graph I showed you. So I may be catching hold of the patient here, and if I start him on ACE inhibitors or ARBs, ये जो slow down होते जा रहा है, decrease होते जा रहा है GFR, it may slow down. So he may reach, I'm not saying that it will totally prevent me from going to the dialysis. He may reach dialysis, but जो disease के onset के 25 years बाद dialysis पे जाने वाला है, now he may be able to reach that stage by 30 years, 32 years. So it does make a difference. Yes. And there is a fourth class of drugs which is only recommended. The first three interventions that I mentioned, doesn't matter whether I'm dealing with type 1 diabetes or type 2. सबके लिए HbA1c less than 7 का गोल रखेंगे, BP का गोल रखेंगे less than 130/80, and सबके लिए if there are no contraindications we will give ACE inhibitors or ARBs. But for type 2 diabetes there is one more drug which is helpful in slowing down the drop in GFR, and that is SGLT2 inhibitors. It is not recommended for type 1 diabetics as of now, because use of this in type 1 diabetics is known to trigger or precipitate development of euglycemic DKA. So of course I don't want to take that risk as of now. So I will keep the use of SGLT2 inhibitors restricted to type 2 DM patients. Type 2 DM patients. Right, so this is the summary of our diabetic nephropathy. So let me give you a quick recap. What is diabetic nephropathy? It's one of the major complication of diabetes which affects 20 to 40% of the diabetics, and it is responsible for 2/3 of all cases of end stage kidney disease and 2/3 of all cases of patients who are undergoing dialysis today. What are the risk factors? Poor glycemic control, presence of comorbidities like hypertension, smoking, dyslipidemia. Of course, genetics plays an important role, and co-exposure to the nephrotoxins during the course of the illness. When someone develops this diabetic nephropathy, he progresses through stages. So there is a natural course of the illness. Initially, presence of high amount of blood glucose pushes your nephrons to do hyperfiltration. During that period, GFR increases, but because of the hyperfiltration, there is glomerular injury. Once the glomerular injury sets in, the GFR goes on decreasing, and patients start, because of the glomerular injury, now patient starts losing albumin in urine. So two things are happening. The GFR is decreasing and I'm losing the albumin. This decreasing albumin, like loss of albumin in the urine, in the initial stages when it is 30 to 300, we will call it as microalbuminuria. When it is 300 plus, we call it as macro. When it is in the macro stage, we call it as overt nephropathy. When it is in the micro stage, we call it as incipient nephropathy stage. And once the GFR is severely decreased and we start seeing all the complication of chronic kidney disease, we call it as end stage renal disease. So एक natural progression है which evolves over several years. Catching hold of the patient or recognizing them in the early stages, pre, silent or incipient stages, we may be able to reverse the nephropathy if we keep the glycemic control good. Later stages, completely reversal to possible nahi hai, but we can slow down this drop in the GFR. So whoever is likely to reach the dialysis 10 years down the line, if I manage the patient well, I may push it to 15 years or 20 years down the line. How do I do that, or how do I achieve this slowing down of the progression of the disease? We learned about the drugs, right? ACE inhibitors and SGLT2 inhibitors are known to slow down or halt the disease progression, decrease the albuminuria. So I would say, when I say this halt or disease progression, that also means decrease albuminuria. And apart from that, good glycemic control and achieving the target BP. So that completes our basic understanding of diabetic nephropathy. Now we will talk about diabetic neuropathy. Now diabetes is also known to cause damage to the nerves. Now what all kind of nerve injuries diabetes can cause? There is an entire spectrum of injuries it can cause. One, it can cause polyneuropathy. Polyneuropathy. It is known to cause autonomic neuropathy. It is also known to cause mononeuropathy. And mononeuritis multiplex. We'll try to understand the meaning of these words and then we will dwell a little more details. Okay, so first, polyneuropathy. What do I mean by polyneuropathy? Poly means, of course, multiple. Neuropathy means damage to nerves or neurons. So when we say polyneuropathy, we're referring to multiple nerves affected diffusely, non-selectively. Non-selectively matlab they are not choosing ki I will affect the median nerve but I will spare the ulnar nerve, or I will affect the sural nerve but I will spare the femoral nerve. No, diffusely body में जितने भी nerves हैं Diffusely, they are being affected non-selectively, multiple of them, then we call it as polyneuropathy. When only one nerve gets affected, we will call it as mononeuropathy. If multiple nerves get affected but not diffusely, means selectively, कि हाँ एक ulnar involved है, एक let us say femoral involved है, एक sural involved है, but median नहीं है, radial नहीं है. So it's like multiple nerves, more than one. In such cases, we call it as mononeuritis multiplex. Right? Let me tell you again. Polyneuropathy refers to diffuse involvement. मतलब सर से पांव तक जितने भी nerves हैं सब involved हैं. Diffuse involvement of all the nerves, we will call it as polyneuropathy. If only one nerve is affected, we will call it as mononeuropathy. If more than one, but not diffuse involvement of all the nerves, then we will call it as mononeuritis multiplex. Apart from that, autonomic nervous system, autonomic neurons, the sympathetic, parasympathetic neurons can also be affected by diabetes. Now the question is, among them, which one is the most common? Polyneuropathy is the most common. What kind of polyneuropathy we are getting? Is it affecting the sensory neurons or motor neurons? And why polyneuropathy? See, in diabetes, when these advanced glycation end products are increasing, polyol pathway is activated and other toxins are being generated, can they selectively choose like, okay, I will target the ulnar nerve, but I don't want to touch the radial nerve? Of course, they can't do, right? Because all these advanced glycation end products, toxins, they will be distributed to all the neurons. Through blood supply, they will go to all the neurons. So they will cause damage to all the neurons. So that's why it will be diffuse involvement of all the neurons. So polyneuropathy is much more common than mononeuropathy, mononeuritis multiplex, or autonomic neuropathy. Now, when we are talking about this polyneuropathy, generally the neuropathies cause the involvement of longest neurons more than the shortest neurons. Now tell me why that happens. Just imagine that there is one nerve which is taking this long course and there is another nerve which is taking this short course. Okay. Now when I send blood supply to these both the neurons, will I send the equal amount of blood supply to both the neurons? Of course not. The longer neuron will receive more blood supply than the shorter neuron. So when my blood has advanced glycation end products, high amount of sugar and the sugar alcohols, which nerve will receive more? The longer nerve will receive more of these toxins. So who is more likely to get injured? The longer nerve, having received more toxins, is more likely to get injured than the smaller nerve. So in simple words, longer the course of the nerve, earlier to get affected, right? Now you tell me, let us take the example of the upper limb. I have small muscles in my hand, right, which are helping me move my fingers, the grip and all. There are small muscles in my hand. There are also muscles in my forehand which are helping me move wrist and all. And then I have relatively larger muscles around my shoulder joint, arm, biceps, triceps, all these. All of these are getting nerve supply from which part of the nervous system? Of course, from the spinal cord, right? To be more precise, from where? The cervical segments, because brachial plexus is giving out the nerve supply to the upper limb, right? Brachial plexus gets formed from C5 to T1. So cervical segments form the brachial plexus, and from the brachial plexus, our ulnar, medial, axillary, radial nerves, they all originate and they supply the muscles of the upper limb. So if the nerves are originating in the cervical segment of the spinal cord, tell me which one is carrying the longest journey? The one that is starting in the cervical segment and going to my deltoids, or the one that is starting its journey in the cervical segment and going to my small muscles of the hand? Of course, the one that is starting the journey in the cervical and going to small muscles of the hand. This is the longest nerve, right, in the upper limb. Shortest is the one that is going to the deltoids or shoulder girdle muscles. So in neuropathy, diabetic neuropathy, which nerves are likely to be affected first? The one which is taking the longest journey, right? So which part will start showing the involvement of nerve? Mainly the hands. Next, the forearm, right? So can I say that the involvement is distal? The distal parts of the body gets affected first. Same, take the example of lower limb. Lower limb blood supply, the nerve supply mainly comes from lumbar plexus and sacral region, right? So lumbar plexus forms majority of the nerves for the lower limb and some contribution from the sacral. So lumbosacral segments of the spinal cord are responsible for the nerve supply to lower limb. Now some nerve originate in the lumbosacral region and goes to my thigh muscles, and some nerve originate in the lumbosacral region and go to my feet muscles. Who is having the longest journey? The one that is going to my feet muscle. So who is going to get affected first? The one that is going to the feet. So distal parts of the body, because longer the nerve, more exposure to toxin, early to get affected. So distal parts are the ones which get affected first. So we end up getting something called as distal sensory motor polyneuropathy. Distal sensory motor polyneuropathy. Within that, sensory gets affected first than motor. Sensory gets affected before the motor nerves get affected. So now tell me, distal sensory motor polyneuropathy with sensory involvement happening earlier than motor. So what symptoms these patients will come to us? So when someone develops this distal sensory polyneuropathy, so sensory starts first, followed by motor. Motor is usually a late manifestation. Sensory neurons are the most vulnerable neurons to the injury by advanced glycation end products. So what symptoms they present with? In terms of clinical features, they present with something called as positive symptoms and negative symptoms. So negative symptoms are mainly loss of sensation. Once the sensory neurons die, I lose the sensations in the distal parts of the body. But these neurons which are dying, they haphazardly start discharging the neurotransmitters, and that neurotransmitter haphazard discharge start giving out the signals to the brain that okay, something is going on with that area, and the patient starts experiencing some abnormal symptoms. Those abnormal symptoms we call it as positive symptoms. Simple. इतना सही समझना है कि नर्व्स का काम क्या है, सेंसरी नर्व्स का. जब स्टिमुलस है, when there is a stimulus, send that signal to the brain, right? Send it to the spinal cord, then it will go to the brain, thalamus and then sensory cortex. जब stimulus नहीं है, it is not supposed to send any signal. So when I give the stimulus, but still I am not able to deliver the signal to brain, and I am not able to feel that something which you should feel but not feeling, those are negative symptoms. But bina stimulus ke, if I start experiencing the pain, normally I should not experience the pain when there is no painful stimulus. I should not experience burning sensation when there is nothing burning my body parts. But if I start experiencing that because of the dying neurons, then we will call it as positive symptoms. So these positive symptoms lead to what we call as paresthesias. So these paresthesias include tingling sensation. Many patients experience that ऐसा लगता है कि कोई पिन या नीडल लेके चुभ रहा है बार बार. So we will call it as pins and needle sensation. Pins and needles and pain. Without a painful stimulus, many diabetic patients keeps complaining that sir पाँव जलते हैं. I forgot to write burning sensation as well. पाँव जलते हैं या पाँव में दर्द होता है. It's common complaints at feet. There is burning. So these symptoms they come to us, and when they come to us with these symptoms, please remember which body parts are most affected. The distal body parts are the one which are most affected. So in terms of anatomy, which parts are considered as distal? Upper limb में, in the upper limb, the elbow joints is the demarcation. Anything distal to elbow joint, मतलब forearm and hands is distal. Arms, shoulder girdle is proximal. In the lower limb, the hip girdle and the thighs are proximal, and the knee joint is a differentiator. The legs and feet is distal. So where all these symptoms are going to appear? The distal parts of the body. That means these patients will have loss of sensations in the hands, feet, maybe as the disease progresses, the legs and the forearms. So where the involvement is going to happen? So they will lose the sensations in the hands, maybe a little bit in the forearm, in the feet, and maybe it will extend into the legs. So can I call this loss of sensation and paresthesia, this distribution, as glove and stocking distribution? Glove and stocking distribution. हम gloves कहाँ पे पहनते हैं? Upper limb, right? Hands, stockings, the feet and legs, right? The girls who wear stockings, where do they wear? The legs and the feet, right? So this is what we will call it as glove and stocking distribution, right? So we call this distribution as glove and stocking distribution of symptoms. Glove and stocking distribution of symptoms. So that is the sensory symptoms, right? So I can call these all as sensory symptoms. But if the disease progresses and motor neurons also get affected, वहाँ पे भी length based involvement, longer the nerve, the first to get affected. So the nerves going from cervical to hand, motor neurons are the first one to get affected. So when I talk about the motor neurons in the lower limb, it is the motor neurons starting their journey in the lumbosacral region and going to the feet are the first one to get affected. So motor symptoms are also going to be distal. Motor symptoms, if they get affected, it is going to be distal. So patient will have distal muscle weakness. Distal muscle weakness. So now tell me what manifestation the patient is going to experience when they develop this distal muscle weakness. For what purpose we use these small muscles of the hand? Distal matlab yahi, distal is here. So for what purpose I use these small muscles of the hand on a day-to-day basis? Don't say writing. See, हम लोग unlucky हैं. We are stuck with a profession. हम like lifelong लिखते लिखते मर जाएंगे. But for a common man, no, writing is not a day-to-day task. Yes, foot drop, good. Upper limb I'm talking about. Yeah. So as a common man, when I get up in the morning, right, I have to brush. Where do I hold? With the small muscles of the hand, right? चाय चाहिए, बिना चाय तो इंडिया नहीं जाग सकता है, right? So we need tea in the morning. How do I hold the cup? With the help of the small muscles of the hand. So I may not be able to hold the brush. हाथ से brush गिर जाएगा, हाथ से cup गिर जाएगा. So what do we call it as? We will call it as grip weakness. So the involvement in the upper limb presents with grip weakness. Grip weakness. Okay. So patients often complain of dropping objects when they have grip weakness. वो क्या complain करेंगे? They are dropping objects. Their complaint is dropping of the objects because they are not able to hold. In the lower limb, yes, very often they develop foot drop. In the lower limb, they develop foot drop. Not just the foot drop. Often, एक बहुत common complaint मैंने सुना है from the patients of diabetic neuropathy, that when they wear the slippers, not the shoes or the modern sandals, but the slippers, when they are walking, to hold the slippers tightly, we need the strength of small muscles of the feet. लेकिन अगर वो weak हैं, they may not be able to hold the slippers. तो वो आगे चले जाते हैं, slippers पीछे रह जाते हैं, right? Slipping of slippers. Slipping of slippers. So these are the common manifestations they will develop when they develop this distal sensory motor polyneuropathy. Majority of the patients will present at the sensory stage. Not well managed, we may end up with the motor stage. जितना भी ज़्यादातर patients हमको sensory stage में मिलेंगे, they come to us with mainly this burning feet or pins and needles symptoms. For a patient, it is very bothersome. क्यों? Because it disturbs the sleep. And who likes the disturbed sleep, right? So they come to us. Most of the patients whom I have dealt with, they come to me in the sensory stage, not at the late stage where the motor involvement also has happened. Okay. Now, how do I screen for these patients? How do I screen for the diabetic neuropathy. When and how to screen. When to screen and how to screen. When के लिए the answer is pretty simple. So if it is type 1 diabetes mellitus, all you have to remember is the same thing that we followed for the diabetic nephropathy. So if it is type 1 diabetes mellitus, at 5 years of diagnosis and then annually. But if it is type 2 diabetes mellitus, at the time of diagnosis, at the time of diagnosis, जिस दिन भी आपने diagnose किया है उसी दिन आपको screen करना. Now how do I screen for the diabetic neuropathy? Yes, the preferred investigation of choice. Chandan Patra, the 10 gram monofilament test, what we also call as Semis Weinstein filament, is not for the screening for the diabetic neuropathy, right? I'll come to that. So if you have to screen, how? So there are two methods. One is physical examination. So if gross abnormalities are not found, then you may not have to do major investigation, but keep doing the physical examination on a regular basis. Second, if you have a suspicion, like patient might have lost the sensations or patient is already complaining of having the symptoms, then the investigation of choice will be nerve conduction study, nerve conduction study or NCS, nerve conduction study or NCS. Now I have a question. Why is it important for us to recognize the diabetic neuropathy? Is it because it is affecting the patient and causing some symptoms? वही main reason है. See, let me tell you an example कि बहुत सारे patients आते हैं मेरे पास, उनका complaint क्या है, सर डायबिटीज हूँ 10 साल से 15 साल से और पैर में बहुत जलन है, ठीक से नहीं सो पा रहा हूँ सर, कुछ तो कीजिए. Daytime the symptoms don't bother them much because they are engaged in activities, but nighttime it does bother. It is disturbing their sleep. So if I give them a sleeping pill, the problem is sorted. ना अच्छे से नींद आ जाएगा. So then why should I be worried about this so much until and unless they have developed this muscle weakness? No, I'm still worried. Why? ये जो sensations हैं, right? All this touch, pain, temperature, all of these sensations, why are they there? Their main objective is to protect our body parts from injuries. थोड़ा सा भी इंजुरी हो तो हमें पता चलना चाहिए कि I have hurt my body part, so that I can take care of it and facilitate healing. But if I'm not aware that some body part is injured, then the injury will, like repetitive injuries will go on happening. किसी दिन उस इंजुरी में इन्फेक्शन हो जाएगा, इन्फेक्शन will spread more rapidly because I am diabetic, my immunity is poor, and then I end up with an badly infected non-healing wound. And on top of that, diabetes also causes atherosclerosis, so blood supply to that area is also reduced. Now I'm in a very bad situation. There is a wound that is not healing, blood supply to that organ is, or that area of the body is reduced, and eventually I have to go for amputation. So presence of diabetic nephropathy increases the risk of diabetic foot and amputations. It increases the risk of diabetic foot and amputations. It is associated with increased risk of diabetic foot and amputations. So I need to handle it not just because patient is experiencing bothersome symptoms, but also to protect his limb from being chopped off in the future, right? So then how do I recognize that patient's limb is at risk of the amputation, or he's at risk of developing the diabetic foot? Of course, presence of neuropathy, yes, it is increased risk, but there is a simple, easy way to identify who is at risk of developing the diabetic foot and eventually develop the amputation. That can be detected by this 10 gram monofilament. Ideal screening test should be nerve conduction study, and we should do it at the time of diagnosis for type 2 DM and at the 5 years after the diagnosis for type 1. But we can use this 10 gram monofilament, which is also called as Semis Weinstein filament. This we should do for all patients of diabetes, ideally during every visit. right? So what is it for? It is for detection of lobes. Detection of lobes. Can anybody tell me now what is this lobes? Lob stands for? Lob stands for loss of protective sensations. So what we do is you get this card. Nowadays it's also available in the form of pen. पेन के टिप पे एक सिंगल थ्रेड होता है या फिलामेंट होता है. Now why am I calling it as 10 gram monofilament? Because when I try to apply pressure, like if I hold this card and it's a tiny ATM card sized, very good, Chandan. Loss of protective sensation. So if I take that ATM sized card or the pen with a tip having a filament and I try to press it on the patient's body parts like hands and feet, mainly used for feet. When I try to press it, वो pressure exert करेगा on the limb. Like let us say that this is a feet that I am looking at. So then what I will do, I will try to apply this monofilament and I will try to press with this monofilament. So when I try to press, as I go on pressing, it starts exerting pressure, but it will not exert pressure more than 10 gram. So once it reaches a pressure of 10 gram, after that, that filament starts buckling. It will not remain straight. It will buckle like this. It can't exert any more pressure. So it exerts maximum of 10 gram pressure. Now for a normal person, for us to be able to protect our limbs, to be able to be aware of the injuries happening, we should be able to perceive this 10 gram of pressure exerted on our limbs. If I'm not able to feel this 10 gram pressure, then my limbs are not safe. When injury happens, I may not be getting aware of it. So if this 10 gram monofilament test is done, when I apply, there are identified pressure points जहाँ पे हम इसको अप्लाई करके देखेंगे कि फील होता है पेशेंट को या नहीं. पेशेंट कहता है कि सर मुझे फील नहीं हो रहा है. नाउ दैट पेशेंट्स लिम्ब इज एट थ्रेट फॉर इंजुरीज. इंजुरीज के बाद का जो कैस्केड है, इंजुरी, इन्फेक्शन, वैस्कुलर डेफिसिट, इवेंचुअली एम्पुटेशन. So this 10 gram monofilament test helps us to identify किन के limbs इंजुरीज के लिए अपने आप को प्रोटेक्ट करने की कैपेबिलिटी नहीं रखते हैं. इट डिटेक्ट्स द लॉस ऑफ प्रोटेक्टिव सेंसेशन. इट इज नॉट द स्क्रीनिंग टेस्ट फॉर न्यूरोपैथी. यू मे हैव न्यूरोपैथी बट यू मे स्टिल माइट नॉट हैव लॉस्ट द सेंसेशन टू द पॉइंट वेयर आपको 10 ग्राम का प्रेशर फील नहीं होगा. सो एज लॉन्ग एज यू कैन फील दिस 10 ग्राम प्रेशर, योर लिम्ब इज safe. But once you are not able to feel this 10 gram pressure, your limb is not safe from the injuries. You will not be feeling those injuries, right? So this is used for detection of loss of protective sensation. This is an important MCQ that has been asked. It says this is not just a straightforward MCQ, but it is also an image based question. एक card और एक thread, उसके ऊपर 10 gram लिखा होगा. They will ask you what is it or what is it used for. INI-CET multiple times asked what is it used for. Every time majority of the students answer it is for screening of diabetic neuropathy. बिल्कुल नहीं, it is for the detection of lobes. Very, very important point. Okay, clear? Now, once I have detected that the patient is having the diabetic neuropathy, right? Now, how do I care? Care of patients with diabetic neuropathy. Because दो चीजें हैं यहाँ पे. पेशेंट्स को symptoms which are bothering, burning sensation, pins and needles, all of that I have to reduce, and I have to also make sure that he doesn't end up in amputation, right? So number one, as usual, glycemic control can slow down the disease progression. So I have to make sure that the HbA1c is kept less than 7%. Less than 7%. Second, presence of B12 and chromium deficiency worsen the diabetic neuropathy. So it makes sense to give them B12 and chromium supplementation, chromium picolinate supplementation. Okay. Third, daily foot examination. Patients should examine their foot daily to see if there is any injury that has gone unrecognized. Daily they should do foot examination. And then 4, once there is development of loss of protective sensations, we should refer to, there is now an emerging specialty called as podiatry. which is concerned with only the diseases of the foot. And diabetes is one of the very important foot disease where amputations happen, right? It is the leading cause for leg amputations. So once they've lost the protective sensations, they may get injured and then they may get cascaded quickly towards the amputation. So they now need specially designed footwear which protects them from the injuries and the pressure points. So for that, we have to refer them to a podiatrist. So this is the care of diabetic neuropathy. So main, as a physician, I can try to control their HbA1c. Maybe if required, I can add B12 and chromium picolinate supplementation. Daily foot examination I will recommend. I will use this 10 gram monofilament during every visit, and whenever I notice that he has developed the loss of protective sensation, I will refer him to a specialist for the foot care. And fifth, for the symptom control, for the paresthesia or the burning sensation or the pins and needles that they're experiencing, sorry, what I can do, are there any pharmacological treatments available for this? Yeah, we can use the neuromodulators like the gabapentin, or pregabalin. And in severe cases where there is bothersome pain, is there anything which is derived from chili that can help these patients? That's an MCQ that has been asked. Yeah, Chandan, very good. In severe cases where pain is extremely bothersome, mainly the pain, severe painful cases, where even gabapentin may not be sufficient or pregabalin may not be sufficient, there is something derived from the chili which can be used as a transdermal patch. Yes, we can use transdermal capsaicin. We can use transdermal capsaicin. So this patch, please remember, it is working on a similar principle that your menthol and other rubifacients work. So this capsaicin irritates and stimulates the neurons, and once the neurons are engaged in transferring the signal coming because of the capsaicin induced irritation, the pain conduction gets reduced. So then the pain gets masked. This is an MCQ that has been asked. They have also asked in one of the INI-CET what percentage of the capsaicin is used. Now there are many locally available formulations which can be used as local creams and all, but ideal, the FDA recommended approach is that you use this transdermal patch at intervals of few weeks of gap. Once you apply the transdermal patch, few short duration of contact, remove the patch, and then patient will have reasonable pain control for several weeks, and then you repeat again. So if that is the case, we will use 8% capsaicin patch. Yeah, it is available in India. Right now we have the 8% capsaicin patch, but of course the utilization by the doctors is less, so it is not widespread in terms of availability. So this is how we manage their symptoms, right? So that is about diabetic neuropathy. Now, while discussing the neuropathy, we learned that the spectrum also includes autonomic neuropathy. Now, why this is particularly important, autonomic neuropathy? Because we know that the regulation of vital functions, lidocaine can also be used locally, but again, because it's short duration of action, not a great choice. Capsaicin, this intermittent patching, gives you prolonged relief from the pain, so that's a better, much better choice. Okay, now we know that heart rate regulation is under autonomic nervous system, right? Your sympathetic tends to increase the heart rate, increase the blood pressure. Parasympathetic tends to decrease the heart rate. Then your GI motility is under your autonomic nervous system, right? Then your the bronchial muscle tone is under the regulation of the autonomic nervous system. So if the autonomic neurons get affected, these functions get disturbed, right? So just like how this diabetic distal sensory motor polyneuropathy was leading to the increased risk of diabetic foot and amputations, similarly, this diabetic autonomic neuropathy is associated with increased risk of cardiovascular mortality. Increased risk of cardiovascular mortality. We'll understand why. It increases your risk of dying if you have the autonomic neuropathy. Why? Okay. So what clinical features I will get when I have this autonomic neuropathy? Now we have sympathetic and parasympathetic, and then generally there is a balance. There is a balance which gives me a heart rate of 60 to 100, normalized intestinal motility and all. Many conditions these balance get tilted. For example, right, like let us say organophosphate poisoning. In the organophosphate poisoning, what happens? The parasympathetic activity increases, right? So if the parasympathetic activity increases, now we know that, let us say heart rate is maintained in the range of 60 to 100 by a balance between sympathetic and parasympathetic, right? There is a fine balance. Now whenever sympathetic increases, the heart rate shoots up because the job of sympathetic is to increase the heart rate. Whenever parasympathetic activity increases, the heart rate drops down because the parasympathetic decreases the heart rate, right? This is the normal physiology. The balance helps us to get this normal range of vital functions. So in organophosphate poisoning, we will have profound bradycardia because the parasympathetic activity is increased. With respect to intestinal motility, parasympathetic stimulates intestinal motility. So that's why when there is organophosphate poisoning, we can have diarrhea, right? So it is playing an important role in regulation of the heart rate, and unfortunately, parasympathetic neurons are more vulnerable. Parasympathetic neurons are more vulnerable than the sympathetic. So as the parasympathetic tone decreases, the first thing that I will notice is my heart rate at rest, which is normally maintained at 60 to 100, now increases, right? So I can have this resting tachycardia. Resting tachycardia, which in itself is bad. Why is it bad? Normally 60 to 100, but if my heart rate is constantly 120, 130, now what will happen to the myocardial oxygen and blood supply demand? More is the heart rate, my myocardium needs more blood supply, it needs more oxygen, it needs more glucose. So demand बढ़ता जाएगा जितना heart rate बढ़ता जाएगा. But diabetes is also associated with accelerated atherosclerosis. ये demand तो आपको नहीं मिलेगा, right? You want more as myocardium, you want more, but your coronaries are also getting narrowed, so you're already getting less. With this increasing heart rate, you need more. You're not going to get that much for sure. So it pushes you towards developing ischemic heart disease, right? Ischemic heart disease, and you eventually will also have dilatation of the left ventricle. So अगर heart rate persistently remains elevated, it can increase the risk of developing dilated cardiomyopathy. We call it as tachycardiomyopathy. Tachycardiomyopathy. All of this is happening because of tachycardia. So we'll call it as tachycardiomyopathy, which is nothing but a form of dilated cardiomyopathy. It's a form of dilated cardiomyopathy. So now once I have developed the dilated cardiomyopathy, my heart will fail. So I will have heart failure. I can die because of that as well. Okay. Then second, this resting tachycardia is not the only problem. With this decreasing parasympathetic activity, of course, unchecked or unbalanced sympathetic activity, so it is pushing your heart to do more. So when heart gets hyperstimulated, there is increased risk of tachyarrhythmias. Tachyarrhythmias. So that can be non-fatal as well as fatal. So including AFib, PSVT, VT and VFib. So especially VT and VFib, we know that they are fatal, so they can kill. That's the second problem. Third, like this patient, these things patient may not be bothering because he may not be aware that okay, ये सब मेरे अंदर चल रहा है and it is pushing me towards mortality. But what bothers the patient? Patient can have orthostatic hypotension. Orthostatic hypotension. Means when we make ourselves upright, normally BP drops. Why BP drops when we get up from a sitting position or a supine position? Our BP drops when we make ourselves upright from sitting or supine position. Why it drops? Because when we get up, gravity makes almost 500 to 600 ml of blood to pool in the lower limb veins, which is not coming back to the heart. So there is decrease in the venous return when we suddenly stand. So if the less amount of blood comes to heart also ejects the less amount of blood. So, and we know that our systolic BP is directly proportionate to stroke volume. So if less amount of blood is coming to heart, our stroke volume will decrease. If stroke volume decreases, systolic BP will also decrease, right? Now, how much it can drop? It can drop maximally 20 millimeters of mercury systolic. So let us say that before standing, my blood pressure was 130 millimeters of mercury systolic. After standing, maximum drop I can see is 110 millimeters of mercury. That's the maximum. After that, the autonomic nervous system counters it. So as the BP drops, my sympathetic nervous system gets activated. Right? Activated sympathetic nervous system will cause vasoconstriction, increased force of contraction of the ventricle, increased stroke volume, it increase in the blood pressure, and it gets countered. It gets normalized. The BP will now come back to what it was. So this drop is not going to remain sustained. That's how physiology works. But once the autonomic nervous system is dysfunctional, this counter mechanism may not work and the BP may drop even more than 20 millimeters of mercury. So when it drops, systolic BP drops by more than 20 millimeters of mercury, yes, BP decreases by more than or equal to 20 millimeters of mercury on standing. We will call it as orthostatic hypotension. Orthostatic hypotension. Chandan, very good, right? So now this for a patient is a bothersome symptom because as soon as I get up, my BP is significantly dropping. So blood flow to the brain is reduced. I can feel dizzy or fainted, or I might even fall down. So this is a bothersome symptom, and it also increases the risk of developing injuries. Okay. Then fourth thing that it can lead to, decreased HRV, right? Can anybody tell me what is HRV? HRV refers to heart rate variability, right? Let us take the example of me. Now, if I go by the books, what should be my heart rate range at rest, right? If I'm talking about my heart rate at rest, it should range between 60 to 100, right? It should range between 60 to 100. But if I'm in a meditation or in deep sleep, will the heart rate be 60 only as like I'm awake? No, because my body's desire or requirements are less. Most of my muscles are not working, right? Only major organs like kidney, heart, brain, even brain is at a relatively resting state. So their oxygen demand, blood supply demand is less. So heart needs to do less work. Heart rate comes down, right? So if I'm in, let us say, meditative state or in sleep, my heart rate will decrease further. My nighttime heart rate goes to around 40. So during sleep, my heart rate goes down to 40. Now I also do regular exercises. So when I start exercising, right, I lift heavy weights, I run the treadmills, I climb, like I'm interested in adventure sports. So during that time, my muscles demand increases, my mental demand increases. So heart rate has to increase. So my heart rate can go up to 180, 190. All sinus rhythm, normal physiological range. Okay. So now what is the range available of heart rate for me? 40 to 180. So this is what we call as my heart rate variability, right? Minimum to max, 40 minimum, max is 180. So I have this much of range of heart rate available to me. So when I don't need, I can drop the heart rate. When I need, means not voluntarily, but during my activities, my heart rate can go up to 180. तो 180 तक का डिमांड मेरा हार्ट मीट कर सकता है. But how am I dropping this heart rate and how am I increasing? It is the autonomic nervous system, right? So when I have to increase the heart rate, my sympathetic activity has to increase and parasympathetic has to drop down. When I have to decrease the heart rate, my sympathetic activity should drop down and parasympathetic activity should increase. That's how I get this wide range of heart rate available to me. This is my reserve. This is what I have with me. But once my autonomic nervous system starts going dysfunctional, this shrinks. Already at rest, my heart rate is more than, it would have been more than 100. That's what we have discussed here, resting tachycardia. During sleep, when it drops, it may not come down to this much, right? Let us say that I develop the diabetic autonomic neuropathy. My resting heart rate becomes, let us say, 90 to 110. So now I have resting tachycardia. That is my resting heart rate range. During sleep, of course, it will decrease, but it will, let us say, it comes to 70. And now when I want to exercise, I may not be able to hit 180. Let us say it can reach 140. So now what is my heart rate range? Minimum is 70, maximum is 140. So my heart rate variability is now reduced. So I have lesser amount of fluctuation in the heart rate available to me. Suddenly, if I put myself in a situation where I need heart rate of more than 140 to do that activity, my heart is not going to give me that heart rate. So when it is not going to give me that heart rate, will it give me the desired cardiac output? No, because what is cardiac output? Cardiac output is equal to stroke volume into heart rate. So अगर मैं heart rate नहीं बढ़ा पाऊंगा तो I will not get sufficient cardiac output. So when I'm not getting sufficient cardiac output, I may not be able to do the tasks that I'm doing at that point of time, right? I burden the heart, coupled with the coronary artery disease and other things that come with the diabetes, I may end up with an ischemic heart disease or a syncope, and both can put my life at risk, right? So nowadays, when we diagnose a patient with diabetic neuropathy, we also measure their heart rate variability. The devices are available. Many of you might be now studying in your physiology as well, right? So these are the manifestations of the autonomic neuropathy. Yes, it also impacts the gut motility, and one of the bothersome symptoms is it causes diarrhea as well. Diarrhea as well. So these patients of the diabetic autonomic neuropathy may have higher heart rate, increased risk of tachyarrhythmias, orthostatic hypotension, decreased heart rate variability, and diarrhea. So these four features, the first four features, put you at increased risk of cardiovascular mortality. Now, how can I modulate these patients' progression? Well, as of now, we don't have any great drug that alters this. Regularly keep monitoring them and make sure the neuropathy also, autonomic also progresses because of the glycemic overload. So make sure that you have a good glycemic control, right? So that is how we are going to primarily focus on the management of diabetic neuropathy. So what I have to remember in terms of MCQs, there are only 3-4 important points. The first important point is that what is the most common neuropathic or neurological manifestation in the diabetic patients? It is going to be distal sensory polyneuropathy, sensory more than motor. So I can combine call it as distal sensory motor polyneuropathy. If you ask me precisely, sensory part is more affected than motor. Autonomic neuropathy increase the risk of cardiovascular mortality. One more MCQ point, this mononeuropathy or mononeuritis multiplex, where single or multiple discrete nerve involvement, the most common cranial nerve affected is an MCQ asked. The most common cranial nerve affected is third cranial nerve. Third nerve palsy because of diabetes is very common, and when diabetic third nerve palsy happens, generally there is pairing of the pupils. Pupils don't get affected when third cranial nerve palsy happens because of diabetes, but the third cranial nerve palsy happens because of some surgical cause like tumor, trauma and all. Pupils will also be affected. So this third cranial nerve involvement in diabetes is pupil sparing. It is pupil sparing. So in many surgery textbooks, they call the third cranial nerve palsy happening because of diabetes as the medical third nerve palsy, which is sparing the pupils because it's because of a medical disease. But if it is happening because of a tumor, compression, trauma, then they call it as surgical third nerve palsy where the pupils are not spared. Okay, that's also an important MCQ point. Here, primarily they will sometimes give the description of glove and stocking distribution or sometimes even image, and then they ask what is the diagnosis, and they may also ask you about the 10 gram monofilament. What is its name? What is its use? Many times students get confused. Its use is not for the screening of diabetic neuropathy. It is for the detection of loss of protective sensation. Screening के लिए still physical examination and neuroconduction study. Majority questions are going to come from what is the time of first screening, and with respect to autonomic neuropathy, main thing I want you to remember is the heart rate variability as a parameter, which is gaining importance in the recent times. Beyond that, what are the manifestations? That's it. Okay, so that's it from me today. I'll see you in the next class. Next class, I'm trying to have a case presentation from one of our students, and through the case presentation, we will learn some points about the neuropathy, some neuro, some diabetes, and because that patient, of course, now requires modulation of their medications, we will learn about insulins as well, different types of insulins, how to adjust to get the glycemic control. So diabetic gastroparesis, one of the good and useful drug is clonidine. We can use clonidine, we can use other prokinetic agents apart from the clonidine. And for the diarrhea, effective drugs include, even clonidine is helpful. The other thing that can be useful for the diabetic diarrhea is cholestyramine, which is also used for the dyslipidemia. Okay, so the 10 gram monofilament is basically a small card or a pen with a filament. Filament की स्पेशलिटी क्या है? ये फिलामेंट अपने आप को स्टिफ रखता है जब तक 10 ग्राम तक का प्रेशर हम एक्सर्ट नहीं कर रहे हैं. जब 10 ग्राम का प्रेशर रीच हो जाता है तो ये फिलामेंट बकल कर जाता है. इट विल नॉट ट्रांसफर प्रेशर एनी मोर. अगर और भी प्रेस करूंगा तो वो बकल होते जाएगा. इट विल नॉट ट्रांसफर द प्रेशर. सो मैक्स प्रेशर this filament can exert on any tissue being examined is 10 ग्राम. तो हम इसको पेशेंट के लिम्ब पे डेजिग्नेटेड पॉइंट्स पे प्रेस करके देखेंगे. हर जगह पे हम प्रेस करेंगे तो ये 10 ग्राम का ही प्रेशर एक्सर्ट करते जाएगा. नॉर्मल पर्सन को ये प्रेशर फील होना चाहिए. जब तक हम इस 10 ग्राम के प्रेशर को फील कर रहे हैं, हमारे लिम्स प्रोटेक्टेड है. मतलब जो भी ट्रॉमा होगा हमको पता चलेगा कि हाँ ट्रॉमा हुआ है, पता चलेगा तो हम उसको केयर करेंगे. अगर छोटा मोटा इंजुरी है तो जो भी ड्रेसिंग बेसिक जो भी करना चाहिए हम करेंगे, तो हम ये इंजुरी और प्रोग्रेस होने से बचा सकते हैं. लेकिन अगर मैं 10 ग्राम का प्रेशर फील नहीं कर सकता हूँ, मतलब व्हेन आई प्रेस दिस 10 ग्राम मोनोफिलामेंट एंड पेशेंट फील्स नथिंग, दैट मीन्स ही हैज लॉस्ट दैट प्रोटेक्टिव सेंसेशन. इस सेंसेशन को जो हमें प्रोटेक्ट करता है इंजुरी से, उसको हम कहते हैं लॉस ऑफ प्रोटेक्टिव सेंसेशन. तो प्रोटेक्टिव सेंसेशन तब तक है जब तक आप 10 ग्राम के प्रेशर को फील कर सकते हैं. अगर 10 ग्राम के प्रेशर को आप फील नहीं कर रहे हैं तो आप प्रोटेक्टेड नहीं हो. आपके लिम्स जब इंजुरी होगा, यू मे नॉट नो इट. सो यू कीप ऑन हैविंग माइक्रो इंजुरीज. दोज माइक्रो इंजुरीज विल cumulatively put you at the risk of developing diabetic foot and non-healing ulcers and eventually amputation तक हमको वो लेके जा सकते हैं. तो ये जो 10 ग्राम मोनोफिलामेंट है, इट हेल्प्स अस टू डिटेक्ट कि हाँ कब पेशेंट इज एट रिस्क ऑफ डेवलपिंग द इंजुरीज और मुझे कब रेफर करके हायर लेवल पे मैनेज करना पड़ेगा. तो इंस्ट्रूमेंट नेम से बेसिकली एक सिंपल सा कार्ड आता है. कार्ड के आगे एक फिलामेंट होता है विच हैज़ द टेंडेंसी टू बेंड और बकल व्हेन द प्रेशर एक्सीड्स 10 ग्राम. इसके लिए हमने एक नाम रखा है सेमीज वाइनस्टाइन फिलामेंट. आपको किसी भी मेडिकल इंस्ट्रूमेंट के स्टोर्स पे मिल जाएगा. ऑनलाइन इट इज ऑल्सो अवेलेबल ऑन द अमेजॉन. सो इवन इफ यू आर एन MBBS स्टूडेंट, keep it with you and start examining for all your diabetic patients for the loss of protective sensations. Okay, so someone was asking me about the dose of cholestyramine. Usually 3 to 4 grams, like 2 to 3 times a day will help reduce the diarrhea, especially when it is difficult to manage with the other medications, the conventional anti-diarrheal agents. So cholestyramine can be added. An added advantage with the cholestyramine is that it also helps you to reduce triglyceride burden to some extent. जो diabetes में एक common problem है. So we can also manage hypertriglyceridemia to some extent along with the management of their diabetic diarrhea. Okay. So Tapa Samantha, of course we are generally not using the 10 gram monofilament for the upper limb because upper limb हम आंखों के सामने दिखता है, तो injuries patients tend to identify easily, mainly for the feet. When you Google, you will get the sheet where जहाँ पे feet के कहाँ पे लोकेशन पे ये 10 ग्राम मोनोफिलामेंट प्रेस करके देखना है. आपको एक शीट मिल जाएगा और those locations we should press and see whether they feel it. Of course, when we are examining, we should ask the patient to keep their eyes closed or look other way and then every time we touch, when the filament buckles, it is no longer straight. जब हमने pressure किया, ये buckle किया, at that time we should ask the patient, did you feel this thread touching your feet? If he says yes, तो वहाँ पे protective sensations अभी भी है. If he says no, then there is loss of protective sensation. Okay, so that's it from me today. I'll see you in the next class. Next class will be hybrid of case presentation, where we will learn about the diabetic complications, how to manage diabetes, and also we'll learn a lot about insulin. So I'll see you in the next class. Till then, have a good time. Okay, so this cholestyramine, as long as the diabetic diarrhea bothers the patient, long-term use do have some minor side effects, mainly GI discomfort, but as long as the diarrhea bothers the patient, we can continue to use it. If we manage their glycemic control well, HbA1c well managed hai, so then the diarrhea may not be bothersome, and you may be able to manage them with the other conventional antidiarrheal drugs alone without the need for cholestyramine. But जब तक regular drugs से manage नहीं हो पा रहे, you can continue to use cholestyramine. Okay, so that's it for me today. I'll see you in the next class. Till then, have a good time. Bye. Chandan, yes, it is available in sachet. It's powder. It's not 3 to 4 grams, तो capsule से नहीं ले सकते. It's available in sachet, almost tasteless. It can be mixed with water and had. Okay.